Years as Dean of the Robert Wood Johnson Medical School and CEO of Robert Wood Johnson University Medical Group, the largest multi-specialty group practice in New Jersey, where he was professor of medicine. Pioneer in the field of quality management, Dr. Paz was among the first to study clinical outcomes in the intensive care unit. Currently, he is an adjunct professor of internal medicine at Yale University School of Medicine and remains clinically active in pulmonary medicine at West Haven's Veterans Administration Hospital. Dr. Paz's presentation today will focus on moving to the third curve of healthcare, which very closely ties to, of course, being the change in healthcare. Please join me in welcoming Dr. Paz.
Well, thank you very much, Steve, for that kind introduction, and thank you all for the opportunity to speak this afternoon. I am truly delighted to be back in Pennsylvania. I used to live here. I worked in Pennsylvania for 15 years, and it's always a thrilling thing to be able to come back and visit. So thank you for this invitation and for the opportunity. I want to talk a bit about what I believe will be a confluence of events that will result in an unprecedented transformation of healthcare in this country. I think it's ripe for that change. I think it's coming, and I think it's coming soon. There are three factors that drive this change. The first, let me get my clicker, is demographic. The second is economic. And the third is technological. And I believe as these three come together, we're going to see an unfolding of events over the next decade that will truly result in changes in the way that healthcare is experienced by all of us in this room and by future generations to come. So let's start with demographic. Americans are getting older and they're getting sicker. Population growth in this country, 323 million people, continues to increase slowly, about 0.77% per year. But at the same time, we're seeing significant increases in the burden of chronic disease in this country. And on this slide, in those blue bars, you can see that there's been a 42% increase in the burden of chronic disease projected between the years 2003 and 2023, while the population has grown by just 19%. And at the same time, we're seeing an increase in the aging of our population such that by the year 2040, 1 out of every 5 Americans will be over the age of 65, and for the first time, we'll see significant numbers of Americans even in the age of 100 plus. A lot of this has to do with the tremendous success of biomedical research and the health care that many Americans receive in this country. Diseases like AIDS, cancer, heart disease that were uniformly lethal just a few years ago have now become chronic illnesses. But at the same time, illnesses that were not even imagined well not that long ago, obesity, end-stage cardiovascular disease, hypertension, dementia are now looming on the horizon because of multiple different factors that will create this increased burden of chronic disease in an elderly population that will be looking for resources to provide the care that they need. But interestingly, against that backdrop, we have a physician shortage. The shortage already exists in some communities. Some of you in this room may have experienced it in different ways. Waits to see physicians, access to primary care, a whole host of issues that are significant. But to make matters worse, it's projected that by the year 2025, there will be a projected shortfall of 90,000 physicians in this country. Add to that the fact that many physicians now have an increasing administrative burden on their plate. And there was just an article in the Annals of Internal Medicine that suggested that for every 1 hour of patient care a physician provides, there's 2 hours of administrative work they must do, either because of the time they spend with an electronic health record or the time they go through some type of regulatory processing that they must do. That limits their availability to provide the care that they were trained to do in the first place. So we believe that there will be shortages of physicians in the future unless things change, And as a result, the way that care will be delivered must change as well. But at the same time, there's going to be changes in how the other health professions interact with patients, we believe, and this will be important as we move to what I'll tell you later is the third curve in terms of the roles and scope of practice of many health professionals beyond physicians involved in creating a team-based approach to delivering care. And then there are the economic factors. Everybody in this room has seen a version of a slide, bar graph like this, that lists the OECD nations and always puts the United States in the first bar as being the highest as a percent of GDP in terms of healthcare spend. Now, I realize that for some of you sitting in the back of the room, it's not so easy to see this slide, so let me try to explain it. This shows the OECD nations, but it looks at the world a little differently. In that light blue on the bottom is the economic spend for healthcare services. The United States, in the bold print, is 11th, not first. Well, why is that? Because in the darker color on top of the blue is the spend on social services. The things that go beyond health care, but are going to be very important, are very important in terms of overall health and wellness for each individual that receives health care in general. And when you look at the combination of both healthcare spending and social service spending, you in fact see that the United States is 11th. And as a matter of fact, this data, which was done in 2011, has been updated. We're now 14th. Many of these other nations, beginning with the Northern European nations to the right of the US, are spending much, much more as a combination of social services and healthcare services. But what also makes the United States unique is, with the exception of those two countries at the very far end of the graph, Korea and Mexico, we're the only one that spends more on healthcare services than on social services per se. And there's a multitude of reasons for this. Every time a patient is in the emergency room because they don't have a home, they don't have access to food, they don't have access to basic services, that's a bed, that's a spot that someone who does need medical services is not getting. And that drives up the cost of health care. It creates challenges in terms of access to care, and it causes, frankly, confusion between aligning resources to support individuals, but at the same time making sure that adequate health care is available to all. I believe that in the third curve, we're going to use technology to help us sort through this issue as opposed to how some of the other countries listed on this chart have addressed it because of the way that Americans think and want to have choice and optionality. But this is an extraordinarily important issue, and let me show you why. This is data from work done by Steve Schroeder and his colleagues McGinnis and colleagues going back to 2002. It looks at what's called determinants of health. Now, there are a lot of different ways that you can measure health and wellness, and the Institute of Medicine just came out with a way to create that measurement 2 years ago. This has been studied in a number of different ways, but the simplest way, and maybe the best way to look at it, is twofold. One, do you live to the age that you're predicted to live to based on the year you were born and your gender? Very simple, but very, very important. Many Americans are not able to live to the age they should be predicted to live to, and in many countries around the world, we know that it's uniform. The second is, if you are asked to rate your own health, how do you rate it? On a Likert scale from 0 to 5. Do you feel that you're very healthy, or do you feel you have poor health? When you look at those two factors of health status, health and wellness, there are 5 determinants. In the bright green are behavioral patterns. It makes up the overwhelming majority of health status, the likelihood you'll live to the age you're predicted to live to, and how you rate your own health. Those behavioral patterns include tobacco use, diet and nutrition, physical inactivity, obesity, alcohol, drugs, violence, high-risk sexual activity, wearing a seatbelt, wearing a bicycle helmet. By far, smoking, obesity, and inactivity are the most important contributors to 40% of the prediction of you living to the age that you should live to. Those are not things in general that the health system per se will address. It's not designed to do that. Those are things that all of us in this room must address as individuals. But yet we confuse the social aspect of our health and wellness with the medical aspect of our health and wellness. Genetic predisposition, 30%. That's the hand that you've been dealt by your parents, the genetic hand that you have. And there are hereditary diseases that will cause individuals, sadly, not to live to the fullest extent. Cystic fibrosis is one example. But I remember when I started out in pulmonary medicine, cystic fibrosis was a disease that pediatricians dealt with. It is now a disease that adult pulmonologists deal with. We've made tremendous progress in biomedical research, in the services offered by hospitals and physicians to address this devastating genetic disease. And there are many, many other examples. We're seeing patients that are now being cured of cancer that just a few years ago were uniformly lethal. So we are making progress. But most of that is really something that you inherit and is something that affects your ability to live to the age you're predicted to. Social circumstances, study after study after study, have shown that poor people do not live as long as wealthier people, and that their health circumstances are just not as good. Poverty, lack of education, lack of insurance, having no sidewalks or bicycle paths, living in a neighborhood that's crime-ridden means that you are concerned or fearful of walking outside. You're not going to get exercise. If the only place near your home where you can get access to food is a mini-mart attached to a gas station, why is it surprising that you will not have good nutrition? And nutrition, as we said earlier, and obesity are important contributors to living to the age that you're predicted to live to. The environment. There are certain environmental factors that we're all aware of. If your home's on top of a radon mine, something that, being in Pennsylvania as long as I was, I'm familiar with, we have radon mines in this state. We have them in New Jersey and parts of New York. It's an issue. But there are many others. Water pollution, air pollution, lead. These are factors. But they account for 5% of the prediction of one living to their fullest extent, health and wellness. I left the one as a physician that's of greatest interest to me, which is healthcare. 10% of the contribution to health status comes from healthcare. 10%. The other 90% comes from everything else on this page. But 10% is what we spend $3.2 trillion on in this country, 17% of GDP. And yet, many of us are frustrated by the fact that Americans' health and wellness is not what it should be. And we're spending all this money on it. And we're number one of all the OECD nations in healthcare spending per capita. When yet, it's not the healthcare spending per se that is the largest determinant of health status. It's all the other things, many of which are social. Why are we surprised with the outcomes that we have? But to make matters worse, if you look at that pie chart, one third of the $3 trillion goes to total waste. 60% of it is administrative waste. 40% of it is medical or clinical waste. Well, what's medical or clinical waste? That's when one doctor or one hospital does a bunch of tests, and the patient then goes to another hospital, and the other hospital isn't aware of the tests that were done, so they're all repeated. That's medical waste. Not following evidence-based guidelines. When a journal article or a book says this is clearly what you should do, but it's not being followed, that's medical waste. What's administrative waste? All the complexity that everybody in this room, unfortunately, is very familiar with. Or some of the things I mentioned before. Spending 2/3 of a physician's day dealing with administrative issues when we could find simpler ways to be able to do that is administrative waste. Fraud is administrative waste, and the list goes on and on. But these are the contributors. They're listed here on this slide, and there's no need for me to go through each of them in any great detail. I would argue, demographics, economics, that this bubble, because it is a bubble of waste, probably one of the largest economic bubbles we're sitting on in this nation right now, is ripe for disruption. And healthcare, just like any other industry, is ripe for disruption when there's inefficiencies. And $1 trillion of inefficiency will sit and wait for the kinds of disruptions that will come through the third trend that I mentioned, which is technology, to cause it to change. So the idea of disruptive innovation, or technology coming in and disrupting any kind of industry, was coined by Clay Christensen about a decade and a half ago. And Clay, who's a professor at the Harvard Business School, has used a number of different examples in different industries to talk about how technology and how innovation can cause disruption. So one of his examples is obviously in retail. Small retail stores impacted by the Walmarts of the world. Walmart's is now impacted by Amazon. I think you all know that story well. Remember large steel mills? Large steel mills are impacted by small mini mills. See that change. Cell phones, interesting one. My dad was a lifer at IBM. I remember when he used to come home from work with punch cards. This was in the late 60s. And they were building these large mainframe computers. Well, in the old days, people used to do calculations on paper and pencil. I know I'm really dating myself. And when I was in graduate school, I used to sell slide rules at the MIT Coop, and I told my kids about this. They didn't even know what I was talking about. But people used to do that stuff. And all of us were out in the periphery doing this on our own. But what happened? The technology, the IBM and the IBMs of the world, made it easier and easier using technology to move everything to the middle. All information, all the work, all the processes moved from the periphery, paper and pencil and slide rules, to the middle, to these big mainframe computers in the 60s and the 70s. But then what happened? Technology got better and better and better. The mainframes became desktops, the desktops became laptops, and the laptops became these, which now have the computing power that surpasses those big, huge computers that were sitting in a single spot that were very difficult to get access to. Sound familiar? Why do we think healthcare is going to be any different? When I was a kid growing up, we had a GP. The GP used to come to our home with a black bag. I know I sound like a dinosaur, but this is really true. Used to come to I was a little kid, used to come to our home with a black bag, and my mom would pay him in cash. That was the form. There were no forms, there was no nothing. Saw the kid, gave him a shot, $10 or whatever it was, goodbye. This fine doctor, who was a terrific man, did not spend 2/3 of his day doing administrative work, trust me. He spent the majority of his day doing what he loved, what any physician loves to do, which is to take care of patients and make them better. The first hospital in America was here in Pennsylvania, 1751, the Pennsylvania Hospital. What happened before then? Where did you get care before 1751 if you lived in the Commonwealth? It wasn't called the Commonwealth then. You got it at home. Why do we think healthcare is going to be any different? I ran a very large health system here in central Pennsylvania. We had a huge hospital facility. We kept on adding to it and making it bigger and bigger. But every time we thought about making it bigger, we thought about adding more outpatient facilities, surgery centers, clinics. The last thing I wanted to do was add more and more hospital beds. because that's the last place any of us wanted to spend any of our time. We built a cancer institute in Hershey, beautiful facility, not one inpatient bed. We had same-day hospital beds because the last day that any patient who has cancer wants to spend a minute is inside of a hospital. They want to come in the morning, they want to get their treatment, and they want to go home to be with their family. Even if it's too far away to go to their home, at least they could go across the street to the Hershey Lodge and still be with their family. And by the way, not get exposed to all the kinds of things that are floating around hospitals, frankly, if you have no immune system. That's what all of us want. And that's what we have to continue to drive to, because if we do that, we're going to have healthier patients, all of us will be healthier, and we can find ways to reduce the cost of health care. So what we're doing, basically, is we're moving to the third curve. The first curve is what I described before, good old-fashioned fee-for-service medicine. And we've been living in that world for over 100 years. Aetna wrote its first health insurance policy in 1899. But in those days, health insurance was like car insurance or home insurance. It was for catastrophic situations. In the 50s and in the 60s, and particularly in the early 60s with Medicare and Medicaid, insurers became payers. And this whole idea of insurance companies now paying for things was totally new, and it's grown to what we have today. But imagine if I called my homeowner's insurer and said, the light bulbs are out, can you please pay for new light bulbs? They'd think there was something seriously wrong with me. It's unique to health insurance that we have this system. But it is what we have, and we're going to have to think about what the next chapter looks like, which I'll get to in a minute. Ian Morrison, who's a healthcare futurist in California, talked about the second curve. And he didn't start out as a strategist in healthcare. He was has a PhD, and he's in industrial engineering, I believe, and he started looking at other industries. And he said, when an existing industry transforms itself to address the economic opportunities to ensure that it can be successful in the future, they go from being a first curve industry to a second curve industry. When Walmart's now is very, very active in having web access to look like another company we're all familiar with, they're moving into the second curve, even though they already were in a second curve company. But it's this ongoing transformation that they have to continue to go through so they can be successful into the future. That's happening in healthcare. The second curve, in many ways, is population health. We've heard that term over and over again. Not 100% agreement, if you ask many people, what population health means, but we all kind of get the concept. I would argue that population health has been around for a long time. It started in the 1840s in England with the public health movement, trying to eradicate infections that were killing many people from water and airborne disease, limiting air pollution from coal mills in London, and doing a number of things to improve health of populations in the community. It came to the United States in the early part of the 1900s. Schools of public health started to pop up, addressing many of these very, very important issues. There's a great school of public health here in Pittsburgh. That continued to advance to the community health movement in the 1950s. A whole cohort of medical schools were started to really push primary care and care into the community. Robert Wood Johnson Medical School was one of them, as a matter of fact. The idea of, can we do things in the community through primary care to improve health status? And the model continued to move forward. But the challenge is that that model did not have any type of an economic framework. So that happened most recently with the move to value-based reimbursement, to all the forms of value that we're seeing now in Medicare. And as you know, just this year alone, bundled payments in over 68 districts. The move towards accountable care organizations, and increasing risk on the basis of various systems forming around care in the community. But I think very quickly we're going to move from the second curve of population health to the third curve of personalized health. And that's what I want to spend the remainder of this talk on. So this basically shows the payment models that have evolved, moving from fee-for-service all the way through pay-for-performance, through patient-centered medical homes, to bundled payments, to accountable care organizations, to high-performing networks, to ACO products, and even at Aetna, we have joint ventures now where we work with health systems to stand them up so that they can be full risk-bearing entities, and getting them to what basically looks like capitation, where they can have the dollars to make the right decisions about providing the right care at the right time, at the right place. The first one we launched was with Inova. It's called Innovation Health. It's in Northern Virginia. There are others that are following, and we also have several high-performing ACOs with institutions like Banner and Carillion and other institutions around the country. And those ACOs continue to grow, focusing on population health, curve two opportunities, extraordinarily important. But with the rise of technology and the changes in consumer expectation, and my kids don't stand on a street corner waving their arms at yellow vehicles driving by. They just get out their iPhones and have an Uber car pick them up. And they go over to urgent care centers when they need something done immediately, like a throat swab for strep and a quick prescription. Consumer expectation is changing quickly in terms of what they want out of the healthcare system, and I think technology is clearly going to drive this. And what we're seeing is more and more changes in the way that individual patients are looking for on-demand care, concierge medicine, telemedicine, and digital health through wearable devices and other forms that will personalize health for them so that they can have a healthcare experience that is totally customized or curated, as we like to call it, built around each of them as individuals. This, in their own world, will address many of the challenges that we just described earlier, the demographic challenges, the economic challenges, and the access challenges that right now are significant. And with the rise of higher deductible health plans and the economic realities of the cost of health care being borne by individuals more and more, they're going to recognize that this type of situation, this scenario, will be important for them to create personalized health ecosystems around them. And this is something that we're working on at Aetna right now, where we are curating health experiences around each individual member, and we're starting this as a pilot, which includes social services, nutrition, home health, post-acute care, medical devices, telemedicine, even things like mindfulness. And working with physicians, primary care physicians, hospitals, and health systems to create this curated, personalized health experience in the third curve. Ultimately, at the end of the day, Aetna will transform itself from that traditional health insurance company that wrote its first policy in 1899 to a health logistics company. And we've said very clearly in our Vision 2020 strategic plan, we're transforming from being a health insurer to being a healthcare organization. But in many ways, not in the traditional sense that you would think about here, really as a logistics company that works with providers, works with many of the important institutions looking at social determinants of health. So at the end of the day, we create this future operating model that addresses the funding and financing of each individual's health care, creates the distribution system for making sure that it can be brought and personalized around each individual, that ensures that data and information is transparent and ubiquitous for each individual and for all the parties that interact around that individual, so that ultimately we can address the individuals that have chronic disease or have acute disease and work to create a healthier world for all of them. And I believe, frankly, that this new operating system will empower our operating model. It will result in a seamless end-to-end experience. Will mean that our individual members will want to have a lifelong relationship with us as opposed to an episodic relationship with us. That we can drive care into the local geography. We can allow physicians to do what they do best, but bring in other resources into the community that are going to be important in addressing the other 90% of what's important about health and wellness, and an engagement that creates an experience where each individual, not patient, not member, but each individual feels like they have ownership over their health and wellness and their own individual destiny towards improved health and wellness. To me, it's why I joined the company 2 years ago. I think this is an extraordinarily exciting opportunity and is one that can only be successful in working in partnership with communities. And for that reason, I'm thrilled and delighted to be able to be here with you today and have a chance just to share some of these ideas with you. Thanks very much.